So I'm Dr. Vishali Patil. I'm a transplant surgeon based in Pune at Dinanath Mangeshkar Hospital. I'm also a hepato, pancreas, and a biliary surgeon. The topic today, which I'm going to talk about, is transplantation of pancreas, a small organ weighing about 100 grams, but an important organ as it provides our endocrine, digestive, and metabolic function, which, if disabled, can lead to really problematic life. So the pancreas has also invited a lot of interest, and a lot of Nobel Prize winners have contributed to its research. The most important being Sir Frederick Banting in 1922, at the age of 32 years, discovered insulin. What he changed was a most fatal illness, morbid illness, to something that could be easily managed. Since then, there has been a spark of global interest in this research, and now we have rapid-acting insulins, ultra-short-acting insulin, mixed-charge insulin, long-acting insulins, and different delivery system of insulins like syringes, pumps, painless insulin pumps, and pens, and injectors and inhalers. But despite that, we seem to have a complex recovery process. Majority of hospitalization for patients in India as well as globally, the root cause or secondary cause is diabetes. If the patients try to achieve a very tight sugar control, they tend to develop hypoglycemic symptoms, coma, seizures, while if they try to have a laxity with HbA1c more than 11, they start developing complications. There have been multiple studies which have shown that over a period of time, when the diabetes has been more than 10 years, majority of patients fall in the age group of HbA1c between 8 to 11, and that's when the secondary complication starts. So for an insulin-dependent diabetes mellitus patient, there is either a risk of hypoglycemic unawareness, fluctuating blood sugars, when they try to achieve a very tight blood sugar control. But when they try to have a laxity of it, where they can lead a comfortable life over a period of time, soon secondary complications like nephropathy, cardiovascular diseases, retinopathy start creeping up. I think we are yet to see a diabetic without these complications when the diabetes has been for more than 10 to 15 years. Daniel Petrie et al. Studied 27,000 patients more than the age of 20 years who were diabetic and found that there was a loss of 10.2 years of life for the male patient and about more than 12 years of loss of life for female patients. It shows that despite the modern advances, there's still a need for a good modality to prevent complications of diabetes, to achieve normal blood sugar control, and to have a better quality of life. It is with this quest in mind that Dr. Richard Lillehei, Dr. William Kelly at the University of Minnesota studied on implanting a healthy pancreas into the human body and thus try to achieve a good normal blood sugar control and just a good normal healthy pancreas function. In December 1967, they implanted successfully the first human pancreas transplant into a young female patient and were able to achieve this blood sugar control. Time has passed more than 60 years now, and with modern advances in immunosuppression, good surgical techniques and modification in the surgical techniques, pancreas transplant now provides a good successful outcome. Let's go to the technicalities of the pancreas transplant operation first. It involves step 1, the donor operation. The pancreas is retrieved from a young donor who is usually a healthy pancreas donor, does not have diabetes, does not have the complications of pancreatic diseases, and has a good health history, an HbA1c of less than 7, and has normal serum amylase and lipase levels. The pancreas is procured and preserved in an organ preservative solution, like University of Wisconsin solution. It's packaged in a cooler and transported to the pancreas transplant center. The pancreas can withstand a cold ischemic time of 16 to 24 hours, which is a good sufficient time to reach the transplanting center. On reaching the pancreas transplant center, what you see is that the pancreas over here with its blood supply coming from the splenic artery, the superior mesenteric artery, and a sliver of portal vein, and the C of the duodenum. This is the second part of the pancreas transplant. It involves vascular reconstruction. To achieve a good single large bore vascular anastomosis, the donor iliac vessels are taken and the iliac artery is anastomosed to the splenic artery and the external iliac artery anastomosed to the superior mesenteric artery to achieve a nice Y graft so that the pancreas can now be transplanted and anastomosed to the iliac vessels here and to the inferior vena cava. What about the exocrine drainage? The exocrine drainage of the pancreas, that is a C part of the duodenum, is now anastomosed to the urinary bladder, or it can be anastomosed to the intestinal part, the ileojejunal junction, or about 40 centimeters from the DJ flexure. This allows for the exocrine juices to now flow as physiologically into the intestine. Once these anastomosis are done, the blood sugars start coming down normally, the pancreas starts functioning immediately, and this leads to that the patient does not require any more insulin. Post-operative course is uneventful or standard, similar to a kidney transplant patient. For patients who also have kidney failure or who have nephropathy with a GFR of less than 30, or patients who need a kidney transplant and their kidney disease is from a diabetic nephropathy, they can be benefited by implanting the pancreas and kidney simultaneously in the same operation. For patients who have already received a kidney or who have a good kidney function but have problems with the blood sugar control despite modern advances or are developing complications, then one can just implant a pancreas transplant alone or pancreas after kidney transplant. Having done this, this is what you see as a final image. The normal pancreas in its normal natural position, the donor pancreas in one of the iliac fossa implanted with good anastomosis, and the kidney if needed. Post-operatively, the patient is placed on immunosuppression based on tacrolimus, mycophenolate mofetil, and prednisolone. The hospital stay is about 6 to 7 days. The risk of complications have really gone down now, with about incidence of less than 5 to 10%. The most commonly worried complications are the duodenal leak or vascular thrombosis or vascular bleeding that can occur from the vascular anastomosis. Majority of the patients have a good survival outcome. Let's look at this data from Hans Solinger at the University of Wisconsin, where they published a study of 1,000 pancreas transplanted patients along with kidney. And if you see here, compared with dialysis patients, those who received deceased donor kidney or a living donor kidney, the survival was longer and almost about 90% survival for more than 10 years and about 80% or 60% survival more than 20 years. An incredible jump from what was compared to a living donor kidney transplant. When comparing with other organs, because majority of the time the concern is that are we risking the patient's life when you compare with the liver transplant patient? As I said earlier, with the modern technology and advancement in surgical skills, the safety margin of this operation has really improved. If you look at this data published in American Journal of Transplantation, the pancreas and kidney transplant outcomes are 90% more than 5 years survival, compared to liver, which is about 80 to 85% 5 years survival, showing that survival is definitely better. What does it mean to the patient? Post-transplant, his blood sugar or her blood sugars are less than 100 or 120. The HbA1c is normal, less than 6.5, and the C-peptide deficiency, which was present in a type 1 diabetic, now is back to normal between 2.5 to 3 or higher. How does it impact the secondary complications? If you see for the kidney, which is one of the most common cause that the kidneys fail, is diabetes. And remarkable study or a Samana study published by Fioretto et al. Along with David Sutherland in 1998. And since then, there have been multiple studies which have shown that patients who had nephropathy, if they were implanted with the pancreas during the early stages of nephropathy, for example, as in this patient, who had diabetes for more than 16 years, at the time of operation, who had a biopsy of his kidney done, showed a lot of Kimmelston-Wilson nodules, amyloidosis. After 5 years, there was resolution of the amyloid. 10 years, the kidney glomeruli were almost as normal. So they were reversal of diabetic nephropathy and can be achieved with just pancreas transplant alone. What are the changes on the neuropathy? This is a CCM membrane of the Bowman's layer of the cornea. The first top one membrane, or the picture on the left, is a normal membrane, which shows the main nerve fibers in red and minor nerve fibers in yellow. The one alongside the B picture shows type 1 diabetic patients CCM Bowman's layer with paucity of nerve fibers. But over a period of time, at the end of 12 months or 1 year, you see a regeneration of nerve fibers. Similarly, when you see the impact on cardiovascular diseases, it has been found that the risk of dying due to myocardial infarction or heart failure or developing complications on the heart due to hypertensive disease or angina is definitely less in the kidney pancreas transplantation as compared to kidney transplant alone. That adding a pancreas transplant to this group definitely makes a huge difference. So for an insulin dependent diabetic patient, The problems of hypoglycemic unawareness, seizures, fluctuating blood sugar levels, this problem is solved with a normal blood sugar, normal HbA1c, and prevention of secondary complications. What do we have new in pancreas transplant? Pancreas transplant now can be done in type 2 diabetes patients. The majority of diabetic patients in India and globally are type 2 diabetes. If these patients fall into the selective group of insulin dependency, age less than 55 to reduce the mortality and morbidity, a BMI of less than 32. If they have a higher BMI, they are advised weight control measures or to undergo bariatric surgery. If they have if they are developing secondary complications, and if they have a correctable cardiac disease, any of these factors, these patients can benefit from a pancreas transplant. As you see in the slide from OPT and UNOS data, which studied pancreas transplant patients in type 2 diabetes from 2015 to 2019, the graft function and the outcomes were similar in both type 1 and type 2 diabetes. The more interesting part is that pancreas transplants can now be offered to type 3C diabetes. As gastroenterologists and GI surgeons or hepatobiliary surgeons, we often see these patients with chronic pancreatitis, patients who have undergone total pancreatectomy for benign neoplasms of the pancreas, patients with fibrocalculous pancreatopathy who have got maldigestion problems, malnutrition problems, severe exocrine insufficiency, are unable to tolerate the majority of the diet, started developing blood sugar control problems like little diabetes, labile blood sugar. If implanted with a healthy normal pancreas, they have a good favorable outcome. They don't have to depend on insulin, they don't need exocrine supplements, and they can achieve a normal diet and a better quality of life. Pancreas transplants can be done in living donors also. Raja Kandaswamy at University of Minnesota, Takashi Kenmochi in Japan, and various other centers spread across the US and Asia have demonstrated that you can take distal 2/3 of pancreas from a living donor and implant it successfully in the recipient. Here, the splenic artery and splenic vein are used for the vascular anastomosis, and the pancreatic duct directly is joined either to the bladder or to the intestine. Sometimes the kidney can also be taken from the same donor, and a patient can undergo kidney pancreas transplant if the recipient needs so. For those morbidly obese patients, Jose Oberholzer recently has shown that robotic pancreatic transplant is also possible, thus reducing the morbidity for operation in such a morbidly obese patient and achieving normoglycemia, and therefore helping the patient lead a better quality of life and have a better survival. So what pancreas transplant means to the patient is normal blood glucose level, normal C-peptide levels, normal HbA1c levels, good autoregulation of blood sugars. What it means to the patient is freedom from insulin, no glucose monitoring, no more problems of retinopathy, prevention of progression of complication, a better survival, normal exocrine function. Thank you.